Welcome back to the afternoon sessions of our course. Thank you. Hopefully everybody enjoyed their lunch and had an opportunity to catch up with friends and new colleagues. It gives me great pleasure to introduce my colleague, Dr. Kimberly Workowski, who is a professor of medicine here at Emory University. She works at the Emory Midtown Hospital and HIV clinic. And Dr. Workowski is a world expert in sexually transmitted diseases. And we asked her specifically to give a talk today about ulcerative STIs, because those are some of the most vexing problems that clinicians are faced with, how to differentiate among the diseases that cause ulcers. So we decided not to do this ahead of lunch because we wanted you to enjoy your lunch. And so therefore, Kim, I'll turn the podium over to you. Thank you.
I think the first picture we're going to start with is pretty graphic. Well, they're all graphic. But that's to get your attention. And one of the things I'm going to go through with you is not only sexually transmitted infections, but conditions that look like sexually transmitted infections. So there are my disclosures. And so I'm going to talk about presentations of genital ulcers, but the cliff notes is they don't all have to occur on the genitals. And we'll talk about what to do in terms of how to diagnose them and some management strategies. So here's your first question, but it's not a Slido. So again, I told you it's going to be graphic. So of those 4 conditions here, and I'm going to show you the answers at the end. So you'll see if you see them in a presentation, or you can make your own notes and say 1 through 4, which of those are an STI. They're not all STIs. So you got those down? Okay. Okay, so let's talk about the evaluation of genital, anal, and perianal ulcers that come in. So in terms of infectious etiologies, herpes and syphilis are the most common. And what you know about herpes and syphilis is is by the textbook, and these diseases don't follow the textbook. Also, you've got immunocompromise on top of it, and STIs like to travel together. So they can look very different. We also now need to think about LGV and Mpox. I put down some pictures there of infections that you normally don't see. The first one is chancroid, which we really don't see in the US anymore, and we don't know why. It's gone away. But this is what it looks like with undermined edges and extremely tender, and normally you have bilateral lymphadenopathy. The other picture is donovanosis, and it basically, for a vegetarian I can say this, it looks like hamburger meat. It just like raw granulation tissue, and if you do a tissue prep, you'll see the characteristic Donovan bodies. And that's what's shown in the right panel. And I just mention these because they're not common in the United States, but if your patient has traveled, the PC way is to say sex tourism. In other countries, they can bring this back. So what you want to know about this when you see an ulcer, you think about where they've been, their travel, their clinical presentation, and the epi, and then treat for what you can treat you think is most likely. And then we'll talk about at the end non-infectious etiology. So this is a lot of information about history examination and testing, but I think it's really, really important in view of the global travel, and you've heard about what's going on with Mpox and the moving from areas of the country to Europe and then to the United States. So you want to ask about practices, sites of exposure, and of course travel. Immunocompromise, as I said, can affect everything. Medications, vaccination, and we'll show you why that's important. Whether or not there's pain, adenopathy, tenesmus, discharge. And then when you do an exam, number one, you have to get somebody to look at the genitals because most of the residents don't do that. And so we have to teach them, again, how to do genital examinations. And that means looking at their mouth, looking at their genitalia, and looking at their rectum. And again, that's where this can help, and sometimes even if patients say, I don't do that, we look anyway, because you find stuff if you look. And then realize that STIs can be different places, as I mentioned before. For the testing, unfortunately, we don't have a point-of-care NAT that's FDA cleared. So what you'll see out in the community is a bunch of tests, a multiplex test, they're not FDA cleared, and then they'll call you to ask you what to do about it with a non-FDA cleared test. We see this a lot in OBGYN with all these commercial assays with all these pathogens, and they haven't been cleared and they don't know what to do with the results. So what do we really have? We have dark field. Well, we have it, but you can't find it anywhere. We have syphilis serology, which is decades old, and it has problems. We have a syphilis nucleic acid amplification test only for research only. We've got a NAT for herpes. We've got a NAT for Mpox. We've got chlamydia testing, but not testing for LGV. That takes 3 weeks to get back, maybe, from the state. And then we have a biopsy with immunohistochemistry. So the problem is that nothing comes back at the point of care, and you're left with trying to decide what to do. So let's talk about a case. 49-year-old male with advanced HIV, uncontrolled hepatitis B, lip pain, and anorexia. Do you see the abnormality? I don't think I have a pointer, but there's a white area of ulcer in his lip right underneath his finger. So what am I going to do to test? What test? You're probably going to do a whole bunch of tests, but which of the tests there is most important to make this diagnosis? So I guess I'll give you 10 seconds. Is that right, Fatima? Okay. Because our tests don't come back in real time, it's very challenging, and then you have to decide how to treat this patient and what to do. Okay, we'll proceed. So it looks like herpes, RPR. So people are thinking herpes and syphilis. That's not the answer. Which is good, which is why I wanted to present this. So this is actually LGV that presents in the mouth. And so what I did was do a PCR for chlamydia, and the genotype was sent to CDC, but I was convinced that this was chlamydia in terms of this appearance. And then a month later, I had a second case of a 25-year-old man with multiple partners with a painful oral ulcer and cervical lymphadenopathy. This is extremely uncommon, although what I list there below is a recent review on literature looking at oral LGV. Again, LGV can present multiple different places. And so you need to think about it, and it's treated a little bit differently. These are the main way that LGV can present. Either genital ulcers, mostly in the inguinal area that then break down, or the ulcers can close and you'll see bilateral buboes. The bottom left is a patient that I saw with pseudotumor. So everybody thought he had a cancer. He saw a bunch of GI docs. And they said, we don't know what's going on. I said, well, this is either herpes or chlamydia, and it was chlamydia, both which organisms can cause a pseudotumor. He got better and resolved with appropriate treatment. And the other one is a patient with proctocolitis. If you biopsy that, the histology will look like Crohn's disease. So in the wrong setting, he could go down the Crohn's pathway. So those are the different ways it can present. And for LGV, if you're thinking LGV, you treat empirically because your test is going to take forever to come back. However, if you also have perianal ulcers, you need to think about herpes and treat concomitantly for herpes. This is from a number of years ago, but this was a report from a series of LGV done in an HIV clinic in Michigan, and again showed the different ways that this can present. 2 of the patients presented with penile ulcers, and then also the increase of concomitant STIs at the same time. The other article was just published in one of our STI journals showing the L serotype, and they basically took every chlamydia positive test obtained rectally and did an LGV type just to show what the prevalence was in the Baltimore City Health Department clinic, and the prevalence was, the prevalence was 6%. Most of the patients were asymptomatic. And the associations there for rectal LGV were age over 25, transgender, and a history of syphilis. So it can occur, it can be asymptomatic. We have no data if it's asymptomatic that you need to treat it for longer, but it can be asymptomatic. So again, I'm turning your head around here. This is another case, 34-year-old woman who was non-compliant with her ART, had a low CD4 count, she has sex with men, and she has a painless vulvar lesion. There's no regional adenopathy. Which test would you use to establish the diagnosis? So the important, again, is thinking out of the box. Here's an immunocompromised patient with a painless lesion on her vulva. Okay, I'm going to proceed. So you're going straight to the biopsy. Okay, so what this actually is something called herpes vegetans, which is a cutaneous variant of herpes, only seen in immunocompromised patients. And all the pictures I show below are pictures of herpes vegetans. The take-home point from this is often the culture is negative, the PCR is negative, and the diagnosis is made by biopsy. So those of you that said biopsy were correct, but were you thinking about herpes vegetans? So that's what's important is, so it has a necrotic kind of appearance, and it looks like a cancer, but you don't have a lot of virus. And it's hard to find. So that it's made by biopsy and immunohistochemistry establish the diagnosis. So it mostly occurs around the buttock, but you see a mouth lesion, you see that's an arm, and then the far right picture is a penile shaft. So it can have multiple different appearances. So this is what we think about with herpes, right? You have the vesicles, then they become a little cloudy, and then they go to crust. So we have a great test, a NAT, but the NAT is much more sensitive when you have an intact vesicle and you actually break the vesicle and do your swab at the base. If you do a crust or if you do with a cloudy, your sensitivity is much decreased. When do we do a culture? Only really because a culture is less sensitive when you're concerned about acyclovir resistance. When do I do a serology, and is serology any good? First thing to say, never do an IgM for herpes. It's not sensitive or specific. It's a waste of your time and the patient's money. Number two, serologic testing should be only done in 3 instances. One, somebody that has frequent recurrences with negative virologic tests, including a negative PCR or culture. They've got signs of herpes, but no lab test, and a partner with herpes if the patient wants to know. The problem with this herpes serology is it's got problems both with sensitivity and specificity. It needs to be type specific, and there's a problem. That especially at low optical density reasons, it can be either false negative or false positive. So basically in the STI treatment guidelines, we recommend a two-step process, which is cumbersome, and truthfully, people getting a herpes diagnosis are more devastated than a lot of other things that you would think would be very devastating. I didn't go over the treatment. Nothing's really changed. You just tend to give longer treatment and higher doses for patients that are immunocompromised. So just a little note on serology. I don't want you to read any of this. We don't have any clear guidance in the literature. This is a poster that was presented, you can look at later, at ID Week a number of years ago. It's never been written up. But this highlights the problems with sensitivity and specificity. That's the bottom line. The tests are not good. We have a Western blot, which is the gold standard. It costs anywhere from $60 to $100 at the University of Washington. That's where you need to send it if you need to confirm somebody has herpes. But there's really big problems with the serology. What about acyclovir resistance? How often does that occur? It's really extremely uncommon in immunocompetent individuals. We see it anywhere from 6 to 10% of patients with immunocompromise. It can occur. These are all different presentations that you would look at, would never know that this was herpes. One of the key things on the left is a knife cut lesion. Looks like somebody's taken a knife in a fold. That's herpes until proven otherwise, and it can be very destructive and look like cancer. The slide down below, again, I don't have a pointer, is a kneecap, bottom of a throat, facial lesions, and again, you look at this and you say, oh, that these are very different, and they can look very different in immunocompromised individuals. Most of these are due to thymidine kinase mutations, but you can have mutations in DL8 polymerase. We don't have good options for treatment. Everybody hates foscarnet, right? It's horrible, horrible to tolerate. Patients hate it. We've got topical cidofovir. What you do if you don't know what you're doing is you can burn somebody's genitalia. And it can cause a horrible burn. And imiquimod can work, but you have to apply it carefully and with a Q-tip, again, can cause a burn. So unless you know what you're doing, you don't send a patient with a prescription home unless you know what you're doing, because you'll cause a problem. I want to just tell you about a medication that is in clinical trials, pratelivir. Phase 2-3 study is been ongoing. So I presented this data a couple years ago at ID Week, which is kind of the first in human phase 2 trial. The bottom line is it works. It's a helicase primase inhibitor. It's got no activation through thymidine kinase. It's got a very long half-life. It's still in clinical trials. It's very hard to enroll these patients, but the drug works amazing. So if you've got a patient that has acyclovir-resistant herpes proven, then please contact us or a place near you. There's sites all over the country. The drug actually works very, very well. We'll move to my favorite STI, syphilis. Very good review that was done by Khalil Ghanem a couple of years ago, and one of the nice things here that I want to point out is that syphilis doesn't go from primary to secondary to early latent. It can go to primary to latent to early latent back to secondary. So it can go back and forth. It can look like anything. These are multiple pictures. There's even a patient in the literature that presented with urethritis with unknown etiology that was later proven to be intraurethral syphilis. So again, it can do anything. It can look like anything. So it is something you need to think about. The patient of the lips right in the middle, that's the only lesion he had, is just on the lip. And again, you need to look. You need to examine every orifice and look really well in the mouth because you may miss things. This is the malignant syphilis called Louis maligna, and it can look almost like a bad staph infection, right? And so sometimes it's not recognized. And in these instances, they're usually immunocompromised patients. They have a very high RPR that can be falsely negative. So if you remember back doing the prozone, you have to ask the lab to dilute the sera 1 to 100 so that you'll actually find a positive RPR. Just a couple words about diagnostics. We really don't have good diagnostics. NIH is aware of this and has just awarded research grants. Hopefully they haven't been taken away in terms of new technologies for diagnosing syphilis. Good news is the RADx program, the same program that brought us point-of-care tests for COVID, is actually now looking at a PCR test, point-of-care for herpes, VZV, Mpox, and syphilis. And then the last thing is we have a syphilis lab guidelines. that were recently published last year. So I would refer you to that if you have any questions, or we're happy as ID docs to answer any of your syphilis questions because it's confusing. Just to get you an idea in terms of the sensitivity of these tests for primary, secondary, and latent. In secondary, the tests work well. In primary and latent, we have some problems with test sensitivity. There are 2 FDA-cleared point-of-care tests, but they're not as sensitive and specific as their serologic tests. A couple of things on treatment. There was an abstract that was presented at ID Week about how many shots you should give to somebody with early syphilis. People were giving 3 shots just because they thought 3 was better for them, not for the patient, even though there's no data to support it. And now there's data to support that you don't need to be giving 3 shots for early syphilis. Just 1 shot is fine. Also, the importance of co-infection. If you've got syphilis, you need to look for other things. Chlamydia and gonorrhea can occur in about 1/3 of the time, and most of them are asymptomatic at the extragenital site, so you just need to screen. Mpox. We know there's 2 clades of Mpox. We know we now have 1 and 2 here in the United States. These are some pictures of my patients that I have seen over the years. The top left I want to comment on is because he had a combination of Mpox and herpes, and we've seen horrible presentations of profound edema, rectal bleeding, penile edema associated with herpes. Sorry, I'm on service. Herpes and Mpox, and can really have a lot of problems with GI bleeding. There can also be horrible complications from pneumonia to nodules to encephalitis, eye findings, and what we experienced a lot of clinically was severe rectal pain, strictures, and proctitis. Wanted to mention that Bruce Aldred put together a group of people that looked at our experience here in Atlanta of patients with Mpox. We had severe Mpox in 19%, and the last bullet is important for me, is that preceding Mpox, majority of patients with HIV had a preceding STI within 1 to 2 months preceding their Mpox. Testing is pretty simple at this point. I remember how challenging it was depending on where you were sending your Mpox, whether it was going to the health department or Quest. Everybody needed a different swab. Thank goodness it's much easier now, but the importance of collecting 2 samples, 1 for the diagnosis and 1 for clade. I think Jeff talked to you a little about tecovirimat. And the problems that we don't have really a good antiviral. This is the actual data, and I wanted to show you the data that was presented at CROI. Remember, there was a treatment arm, a placebo arm, and what I want to talk about is arm C, which is the open label tecovirimat, and that's for people with severe Mpox. And the bottom line in all the patients that got the medication, as well as those getting open label, there was no improvement in time to clinical resolution. More data is being analyzed on the PK/PD, and alternative treatments are being looked at. I'm not going to talk much about the vaccine. I know Melanie did a little bit about Mpox vaccine. So now let's talk about non-infectious etiologies of ulcers. And something that you may not be aware of, which is Lyme, which is infectious ulcers that can occur after vaccination or viral infections. So this was a nice recent article. The dermatologists really know about this, but not many other folks know about this. But there was this recent review, Mayo Clinic's experience with, I'll just call them Lyme, and the association with other viral illnesses and vaccinations. So this has been associated with, in particular, vaccinations, COVID itself, COVID vaccinations, mono, flu, group A strep, mycoplasma, as you can see there, and nonspecific flu-like illnesses. So it looks kind of like STIs, right? So I'm going to flip through a bunch of other things here so that you can think about non-infectious etiologies. This is Behçet's disease, and I think you've seen that picture on the right before. That's Behçet's in the mouth and the genitalia. This is a patient that presented with genital herpes zoster, and if you look at the dermatomal distribution, which is the chart on the right, you can see it fits the dermatome, and people don't think about zoster just in the sacral dermatome. So again, this was published in an OBGYN journal, which I thought was fantastic, just explaining that you can have genital ulcerations due to zoster. Fixed drug reactions, and fixed drug reactions like to occur on the genitalia. And can look all kinds of different ways, but I just showed you a couple of examples on the penile glands. These are presentations of malignancies. On the left is breast cancer, on the right is melanoma, and this was the primary presentation of malignancy. Why the patient came into the hospital was because of pain in this area. This is genital pyoderma gangrenosum that presented with recurrent ulcers on the mons and on the inner thighs. And you see down here the comorbidities associated with genital pyoderma. And there's a good recent review on genital pyoderma gangrenosum. And one of the keys here is it's very ulcerated, very thick, and there's kind of a rind around the ulcer. So something else to think about in terms of non-genital presentation. Vulvar lichen planus can cause vesicles and ulcerations, and you may think that this is somebody that has recurrent herpes with recurrent fissures. And the characteristic on panel A below is the erythematous plaque that you see associated with the hairline. So thinking about other dermatologic conditions that can present on the genitalia. And then the last thing is just ending with the dermatophyte strain associated with sexual transmission that was associated with transmission in Europe for a number of years, and we had the first case in New York City last year. And this requires prolonged therapy with terbinafine, and just some additional pictures of what this kind of looks like. And you may think of syphilis, when you see this, or other related things. But again, this is sexual transmission due to a specific fungus. And then my last picture, I'll show you the answers. So the far panel on the left is Behçet's. The middle picture is a woman I saw who was in labor and presented with these lesions and had the kind of ulcerative lesions that were treated by her gynecologist, OB-gynecologist with, they thought it was herpes and were treating with Valtrex. And the other lesions weren't recognized, the condyloma lata that she had a little higher up. So she had condyloma lata associated with secondary syphilis and Mpox. The picture that's a vulva with multiple ulcerations that's very swollen, and that was after a COVID-19 vaccine. I'm not anti-vax, I'm just pointing it out. That it can occur with both vaccine and the virus itself. And then the last picture on the right was a 65-year-old lady presented. She'd been out of care and presented because she hadn't had a PAP in a long time. And they thought it was cancer, and they biopsied it, and that's how they made the diagnosis of syphilis. And then talking to her, she was actually trading drugs for sex, and that's how she acquired the syphilis with multiple partners. And she had secondary syphilis and also was very hoarse. We were concerned about laryngeal syphilis and had her scoped, but she did not have laryngeal involvement, so she had secondary syphilis. So how many of you got all those pictures right? So again, it can be very confusing, and I'm happy to take any questions. I know that was quick, and happy to answer any questions. Thanks.
Kim, when you forgot to put in an adjective when you said it was quick, it was blessedly quick. Well, as questions are coming up, obviously there's now a couple of different studies that have shown that 3 shots of benzathine penicillin is not useful for early syphilis. Are there any advances in treating tertiary syphilis? Any clinical trials data or anything that would alter our standard of care?
No. So the issue with early syphilis is, remember that there was some concern and some treatment failures that were reported early, decades ago, with patients with advanced HIV. And there was some concern about whether or not their immune system can control the syphilis. Members of our community decided we needed to do an RCT to definitively prove that you didn't need 3 shots, even though people continued to do that. And there is now data, you don't need to do that. The problem is when we run into issues with lack of benzathine, what are the other choices that are available? And yes, we can give doxy, but do you feel comfortable sending somebody home with a pill twice a day for 14 days and think they're going to take their doxy for 14 days? We don't know what the minimum time is you need to take doxy for it to be effective. We don't know. And the other issue, I know other people have talked about doxy-pep, people that are on doxy-pep that have had exposure to syphilis. Again, we don't know how much doxy to give for incubating syphilis. And it may, if people do acquire syphilis and are in intermittent doxy-pep, the clinical presentation may be muted. So for tertiary syphilis, one dirty little secret for latent syphilis is we have no data that tells us that you need 3 shots for latent syphilis. So there was thinking about how long it takes the organism to replicate. The thought was that it would make sense to give something at a longer duration for a shot weekly for 3 weeks, but it's based on no data. It's based only on theory. So we don't know that you really need 3 shots for latent.
And that was one of the questions that came up is, if you have somebody that had previously had syphilis and then hadn't had serology for a long time and came back more reactive, would you treat them with 3 shots versus 1 shot?
Yeah, and it really depends on, you have to talk. So one thing, in which you all know the answer, but I have to say it anyway, is syphilis, you don't make diagnosis on the lab test. You have to talk to the patient. You got to figure out have they had sex recently? Has their partner had sex recently? So it's the history taking that's important and the exam. So they may say they don't have anything, but you have to examine and look. Sometimes we don't know. Sometimes they come back. The last time I saw them was 3 years ago. They had a titer of 1 to 4. They come back now and they're 1 to 8. What do I do? Number one, if I don't see anything on exam, and they have not had they have not had multiple partners in that kind of interim, you have to make the decision, do I need to treat or do I need to wait 2 weeks and look again and repeat? If you don't know, you can always repeat the RPR. You can give them a single shot and repeat your RPR. There's not a really good answer for that. I say I rely on my spidey sense and my experience when it comes to that, because I don't have a pat answer for you. Syphilis is hard, and it's hard when they don't have a pre-existing titer. Although if you saw them several years ago, their titer was 1 to 4, and it's 3 years later and they've got a rash of secondary syphilis, they don't need 3 shots. They need 1. They've got secondary syphilis. That's what people forget, right? If they come in with something that looks like secondary syphilis, you don't need to give them 3 shots. Just because your titer was 1 to 4 2 years ago. They have secondary syphilis, they need 1 shot.
So a similar question, somebody that had previously treated syphilis, went to non-reactive RPR, obviously their specific test is positive, and then a subsequent RPR is positive at a low level in the setting of a recent vaccine. Mm-hmm. Should you treat them for syphilis again because the RPR went up a little bit, or what do you do? So
the issue is what he's talking about is you can have false positive RPR based on vaccination. And what I would do is, again, same thing. get a sexual history, talk about exposure, say, I don't know. We could either treat you with a shot, or you can come back in 2 to 3 weeks and I can repeat your RPR. And if the person's reliable and you say, I am not sure what this is from, I don't see anything. So that's kind of how I handle it. This is a negotiation with somebody. No one wants a shot of benzathine if they don't have to have it. So you just try to figure out what would be best. Some patients say, just treat me anyway, if it's okay. Again, the difference there is if the person is at risk for pregnancy or they are pregnant. Then there's no question they get a shot. And I'm sorry if I overtreat you, but I'm worried about not only you, but your baby.
One question about doxy-PEP, or PrEP, I guess. Could it be masking syphilis infection, not preventing it totally, and so that you don't develop a serologic response that's monitored?
Yes, exactly. That's what I was bringing up. So the point is, if you're taking it intermittently, so we know that syphilis incidence goes down, right? But we don't know, it's not zero. So if somebody presented with a muted response, or say you send somebody has syphilis, you send them home with doxy for 14 days because you weren't able to get benzathine, and then somebody stole this just happened, somebody stole their medication, and they got maybe 1 or 2 doses of doxy, and they come back 1 or 2 months later and their lesion has gone away, and you repeat their titer and it has dropped. What do? You give them benzathine. You find a place to give them benzathine. So the point is that there can be, you have to, again, really look to make sure you don't see anything, nothing kind of looks like it, or if you have any hesitation, you just treat. Because I think that there's going to be issues with the serology. The serology is not good. Our test is just not good. And if you're relying on that because that's all we have, that there can be influence of taking doxy for intermittently for whenever they have sex, and it's difficult to interpret serology.
In a correctional setting, inmates are frequently treated with a 4-week course of oral doxycycline because penicillin intramuscularly is not available. Is that an acceptable treatment for early syphilis or even latent syphilis, 4 weeks of oral doxycycline, or what is the guidelines say?
So the issue is that there's not as good data, but truthfully, we don't have really good data for penicillin either. Mm-hmm. We have 1 RCT. And if you go back in history, you remember that if you remember this, if you're old enough, that we used to recommend benzathine penicillin for neurosyphilis. And why did we get away from that? Is because found out that it doesn't reach treponemalcidal levels in the CSF. That's the reason why. So a lot of the syphilis literature is not robust. And some of this was based on theory and piecing things together as best we can. So the issue with doxy, the recommendations for doxy are for, if you're using doxy for primary, secondary, and early latent, it's 2 weeks. For longer than that, syphilis of unknown duration or late latent, it's 28 days.
Right, so 2 for early, 28 for late latent. Mm-hmm. And it's an acceptable alternative if you can't give penicillin.
It is, except that are you going to be assured, again, that what I mentioned is the proviso. Nobody knows what the actual time that you need to give it for it to be eradicated. And people are complaining. It's very interesting to me about when the initial recommendation was made, I'll ship tockets to chlamydia, and the recommendation came out to treat chlamydia with doxy instead of azithro. There was all complaining. No one's going to take it twice a day. How are we going to assure that our patient's going to take it? We're concerned about that. But then we will write a prescription for 28 days for doxy for syphilis and just assume our patient's going to take it.
Another question unrelated to syphilis, since this has been syphilis central. Why don't we give PEP or PrEP for HSV? Why don't we use acyclovir to prevent?
No data on that. So we have data that using it for suppressive therapy So we know that a trial that was done in heterosexual couples showed that there's a 50% reduction in transmission of herpes, but herpes is very difficult to study transmission. It's very difficult. The main way you get herpes is not by lesion to lesion, it's subclinical shedding. It's very hard to study in terms of transmission studies, so we don't have any data regarding that at all. And it's very difficult. How are you going to design something when most of the transmission is done through subclinical shedding? Very difficult. And even with the transmission studies, the efficacy is only 50% to decrease transmission. So that's why herpes is also challenging.
And just final question, with the recent defunding of the STI lab at CDC, where do people get to send their really difficult specimens to? Is it the Emory Micro Lab or your personal home address?
So I would do a shout out to one of our colleagues who's doing the RADx study. So there's the study that I talked about, that's the point of care test for genital ulcer disease and things you can't figure out. There's an ongoing study that Dr. Greg Damhorst is doing through Emory, looking at an etiology for genital ulcer disease. So if you don't know, phone a friend. It's hard. The other thing is, remember, you can always biopsy if you don't know what the heck's going on. Biopsy is really important, but you need to be able to talk to your pathologist, because biopsying even a lesion that you may think is syphilis and everything else is coming back negative, you're going to get a lymphocytic plasma cell infiltrate, but you're not going to see the organism until you talk to the pathologist. An astute pathologist will pick it up, like Carlos Del Rio's wife will pick it up, but again, you need to think about it and talk to your pathologist about it. So the difficulty with the STI lab at CDC collecting specimens, so there were ongoing issues regarding CLIA and regulatory issues that has kind of stopped in terms of submission to CDC after the pandemic. So again, there's other things that if you've got something difficult, I'm happy to help people navigate through things that they can't figure out or they're not sure what to do. So what we'll have to do is go through reference lab, but you have to know what the best reference lab, or to help the pathologist out, know where to best to send the specimen to help you.
Okay, thank you, Dr. Workowski. Thank you, everybody.